So the first question is this: a 62-year-old man with a long-standing history of lumbar degenerative disease presents with worsening lower back pain radiating to both the legs. So we know that if there is back pain which is radiating to the legs, that means something is wrong with the spinal nerve roots. They are getting compressed somewhere. Okay. The pain increases with standing and walking, and the pain is relieved by sitting. He has tried multiple medications. So, what all has he taken? NSAIDs, gabapentin, and short course of opioids with minimal relief. So, out of all of these, when we talk about nerve-related pain or neuropathic pain, typically the helpful medications out of this would be gabapentin, definitely, which helps in calming down the nerves and reducing the amount of pain signals that are given out by the nerves, and NSAIDs up to some extent. MRI of the lumbar spine shows multi-level foraminal narrowing and compression of the exiting nerve root. So as we discussed that this has to be a nerve-related pain, so the nerve roots are getting compressed. Okay, now what is the most appropriate next step in the management? So the first thing that you have to know is what is the diagnosis of this. So this is nothing but lumbar canal stenosis. Lumbar canal stenosis is a very common thing that happens in the elderly, and this is because of changes in the lumbar vertebrae because of osteodegenerative disease. So this is something that lumbar canal stenosis looks like. So what you see is in the lumbar region, your spinal canal that is there, it gets narrowed. Okay, so this is because of your vertebra, they are degenerating and they are compressing on this space that is present. So this area that you can see, this is the spinal canal, this is becoming narrow. Over here it's wide and below it is narrow. Okay, now whenever it gets narrowed, what happens is that the nerve roots that are there in that area that are arising from the spinal cord, the nerve roots get compressed, and when the nerve roots get compressed, you get this typical radicular pain. Okay, so the pain starts from the lower back in the lumbar area and it extends up to the legs. So that is our diagnosis. Now, what is the treatment for lumbar canal stenosis? So when we look at the treatment for lumbar canal stenosis, you have non-invasive treatment or you have invasive treatment. Okay, so in non-invasive treatment, mainly we have physiotherapy, and you can also take some medications like gabapentin, you can take NSAIDs, and along with that you have something which is called as the epidural steroid injection. Okay, now this is not non-invasive, this is minimally invasive. Now all of us as anesthetists have given epidural anesthesia, correct? So imagine in the epidural space, like how we give local anesthetic, instead of giving local anesthetic, what you give is steroid. Okay, now, this steroid that we give, what it does is we know that steroid reduces inflammation. So as you can see in this picture, the nerve roots that are coming out from this area of narrowing, they are compressed. So as a result of this, they become swollen, edematous and inflamed. So the steroids that you give helps in reducing the inflammation and helps in reducing the pain related to this lumbar canal stenosis. So that is a minimally invasive approach to lumbar canal stenosis. However, epidural steroid also works only for some amount of time. In some patients, it may work for a single injection may work for 6 weeks, or in some patients for 3 months. And the patient would have to repeatedly keep taking the injection till the primary pathology has been resolved. So for treatment of the primary pathology, we have two invasive treatments, and that is a spinal cord stimulator. And the last thing is, of course, to undergo decompression surgery. Okay, so in decompressive surgery, what you do is basically you correct this space, and you whatever is the problem, like you have a bulging disc or you have a degenerated vertebra, all of that the orthopedic surgeon will take care of, so that a wider space is created wherever the narrowing of the spinal canal is there. A wider space is created and the compression on the nerve roots goes away. Okay, now for us, let us discuss about the other options that are given over here. So they are saying for lumbar canal stenosis, can we give an intrathecal morphine pump? Now, morphine is an opioid, and typically we use this sort of morphine pump placement only for cancer-related pain or chronic pain which is not responding to anything else. So chronic refractory pain, mostly cancer-related pain, it will not help in neuropathic pain. Okay, so this is not the option for us. percutaneous radiofrequency ablation of the dorsal root ganglion. Okay, so if you are going to ablate, what is radiofrequency ablation? It is nothing but you are using electric current and converting it into heat. Now this heat will go and degenerate or denature the proteins in the nerve, and that will damage the nerve. Okay, so the nerve cannot carry any pain signals. So if you are going to, basically what you're going to do using heat, you're going to destroy the nerve, or you're going to destroy, in this case they are saying destroy the dorsal root ganglion which carries the impulses. Even if you destroy the dorsal root ganglion using heat, you're going to only affect one level, okay, because you will be destroying the dorsal root ganglion only of that single level. Okay, now when you look at this picture over here, this pain of lumbar canal stenosis is at multiple levels. You can see it as this 1, 2, 3, 4, almost 4 level pain. So here it is not going to be useful to do an RFA. Then the next thing is epidural steroid injection. So as we discussed, this is the treatment that we do, minimally invasive treatment, when a patient comes to us for lumbar canal stenosis. And the last thing is spinal cord stimulation. So suppose your patient does not have relief with epidural steroid and he's in acute pain, he's not able to do his daily activities at all. Then you can suggest, if he does not want to go in for corrective surgery, he can go for spinal cord stimulation. In spinal cord stimulation, what they do is that they put this stimulator in the back, and basically you're going to give electrical signals to the dorsal column. Okay, the dorsal column is of the spinal cord is the one that carries the pain sensation. Okay, now they had asked me this in my viva, that what is the idea behind spinal cord stimulator. So I had got an X-ray, and the X-ray had a X-ray of the back, and the X-ray had a spinal cord stimulator over there. And that sir asked me what is the underlying working principle behind the spinal cord stimulator. So the answer is, it is based on gate control theory of pain. Okay, so what is gate control theory of pain? So imagine that there is a door. When you open the door, the pain signals are passed. When you close the door, the pain signals are inhibited from going to the brain. So when I open the door, the pain signals go through the door and reach the brain, and I can perceive pain. But when I close the door, then the pain signals are inhibited. They don't go to the brain, and my brain does not perceive that there is a painful stimulus. Okay. Now, what opens the door? What opens the door, or what opens the gate, is activation or stimulation of your C fibers and A delta fibers. What closes the door? What inhibits the signals from going to the brain, or what closes the door or the gate, is non-painful stimuli passing through the A beta fibers. Okay. Now, these A beta fibers are stimulated by touch. They are stimulated by vibration. Okay, they are stimulated by large movements. So what do I need to do? I need to make sure that the gate remains closed. How do I need to make sure the gate remains closed? By constantly stimulating the A beta fibers. How do I stimulate the A beta fibers? By giving the sensations or stimuli that stimulate the A beta fibers. What is that signal? That is your vibration. Okay, so the spinal cord stimulator will do nothing, but it will stimulate your A beta fibers. As long as the A beta fibers are stimulated, the gate will remain closed. If the gate remains closed, the pain signals will not go to the brain, and the patient will not be able to perceive the pain. Okay, when will the gate open? When you stimulate the C fibers, or when you stimulate the A delta fibers. C fibers and A delta fibers are stimulated by some sort of painful stimulus. Okay, so suppose I take a needle and prick the patient in the back, your C fibers, A delta fibers are stimulated, and they will open the gate, and painful stimulus will happen. So what I'll do is, I will prevent the gate from opening. How do I prevent the gate from opening? By stimulating the A beta fibers, and by making sure that the C fibers and A delta fibers are not stimulated. Okay, so that is called modulation of pain signals before they reach the brain, and this is called as the gate control theory of brain. Gate control theory of pain. That is what spinal cord stimulator works at. Okay. Next one. A 60-year-old man with advanced gastric carcinoma presents with severe constant upper abdominal pain. And so there is upper abdominal pain radiating to the back. Okay, so most probably upper abdominal pain radiating to the back is very classical of pancreatitis. But over here they are saying that patient has gastric carcinoma. So maybe it is because of the gastric cancer. All right. Pain worsens after meals and at night and has become unresponsive to opioid analgesics. So whenever your patient has cancer-related pain, you will see that pain physicians always tend to give them opioids. However, this has now become refractory to opioids. So you want to do some intervention. So in the intervention, you're planning to do a celiac plexus block, which is the most significant risk associated with this procedure. Okay. Now, what is the celiac plexus? So the celiac plexus is nothing but a group of nerves. Now, what type of nerves are these? So if you see in the picture over here, this is our T12 vertebral body. And in front of the T12 vertebral body, you see the aorta, and just lateral to it, you will see the inferior vena cava. Okay. Now, in front of the aorta, exactly, you will be able to see two ganglions, and this is nothing but the celiac ganglions. Now, they commonly ask in the exam that what is the celiac plexus made up of? Okay. So when you talk about celiac plexus block, remember the celiac plexus is basically an autonomic ganglion, and it is made up of sympathetic and parasympathetic nerve fibers. Okay. When we talk about parasympathetic nerve fibers, it comes from the vagus. And when we talk about sympathetic nerve fibers, so here you have three types of nerves that are formed in the celiac ganglion. So you have the greater splanchnic nerve, you have the lesser splanchnic nerve, and you have the least splanchnic nerve. Okay. Now, if you want to know about the innervations of all of these, the greater splanchnic nerve is from T5 to T9. Lesser splanchnic nerve is T10 to T11, and least splanchnic nerve or lowest splanchnic nerve is T12 level. Okay. Now, this is the basic that I wanted to tell you about the celiac plexus. So, celiac plexus is made up of the autonomic nervous system ganglia, autonomic nervous system fibers. Sympathetic comes from T5 to T12, and parasympathetic comes from vagus. All right. So, what happens? Now, if you see between the sympathetic and parasympathetic also, the sympathetic has a major component in the celiac plexus as compared to parasympathetic. Almost 7 levels of thoracic nerve roots are involved in this, okay, T5 to T12. So they are asking over here, when I block the celiac plexus, what is the drawback that I may see? So if you're going to block the celiac plexus, you're going to block the sympathetic nervous system. If you're blocking the sympathetic nervous system, we know that the sympathetic nervous system is a fight and flight system. What is its work? Its work is to cause vasoconstriction, to increase the blood pressure, to increase the heart rate. Okay. So all those things will be countered or blocked. So what will happen to my blood pressure? My blood pressure will fall. Sympathetic nervous system causes vasoconstriction. When I block this system, there will be vasodilation and there will be pooling of the blood. So as a result of this, I am going to get hypotension. So hypotension is one of the common side effects that I will see with celiac plexus block. Okay. Now, other thing the other options that they have given is paralysis of the lower limbs. Now, paralysis of lower limbs or paraplegia can happen if you are going to be dealing with your spinal nerve roots like the lumbar spinal nerve roots. Okay. Now, we are not managing anything about spinal nerve roots over here. So, the lumbar nerves are not involved. So, there is no point of paralysis of lower limb. Pneumothorax is not possible because you are doing this in the upper abdomen. Okay. So your celiac plexus is where we are accessing the celiac plexus. Now you can see in this picture over here, they have put needles from the side, and if you go to see, the needles are going at T12 vertebral body level. Okay, so it is way below your lung, and you are definitely not going to puncture any part of the pleura while you are performing your celiac plexus block. So pneumothorax is also out of the picture. Then your other option over here is retroperitoneal hematoma. Now retroperitoneal hematoma definitely can be a complication of celiac plexus block. And why? Because you can see that the celiac plexus is closely related to major blood vessels like aorta and IVC. However, celiac plexus block is strictly performed under radiology guidance, and it's not that you will just give the block just like that blindly. Okay, so when you're performing it under radiological guidance, you're looking at the vessels, there is least chances of you puncturing a blood vessel. So retroperitoneal hematoma, even though it is possible, it has a very low incidence of happening, but high incidence of happening is that of hypotension because you're blocking the celiac plexus, which is an autonomic plexus. Okay. Now, just for your information, celiac plexus supplies which abdominal viscera? So because most of the upper abdominal viscera that are there, like liver, gallbladder, stomach, spleen, pancreas, duodenum, adrenals, kidneys, they are provided by the celiac plexus. Okay. All right. Now let's look at the next question. A 59-year-old man with chronic low back pain secondary to lumbar facet arthropathy undergoes a radiofrequency ablation procedure. So you have chronic low back pain and you're giving RFA for long-term pain relief after conservative measures fail. What is the primary mechanism by which RFA provides sustained analgesia? Okay, so basically what they're asking you is, how does radiofrequency ablation work? So RFA works by selective destruction of nociceptive nerve fibers via heat lesioning. Okay, so what happens in case of RFA? So in RFA, you're giving a radio frequency current. Radio frequency current is in the range of 300 to 500 kilohertz. Okay, now when you give that current, that electrical energy gets converted into heat energy. Okay, and what this heat energy does, so have a look at this picture over here. I've just shown you RFA of genicular nerve, that is the nerve supplying the knee, for example. Okay, so what you do is that you target your electrical energy to the tip of this electrode. Okay, when your current reaches the tip of the electrode, there is a change in the energy. The energy changes from electrical energy to heat, and this heat will act typically on that pinpoint area where you are pointing the electrode, and that heat will cause denaturation of the proteins that are there inside this nerve. Okay, when the denaturation of the proteins that form the nerve happens, basically the nerve becomes absolutely abnormal and it stops carrying the pain signals. Okay, so this is how we use radio frequency ablation. What are you doing? You are targeting electrical energy to one spot at the tip of the electrode. When electrical energy reaches that spot, it gets converted to heat energy. When it gets converted to heat, the heat will cause heating up of the nerve, and that leads to denaturation of the protein and damage of the entire structure of the nerve. So once the structure of the nerve is damaged, it cannot carry any pain signals. So that is the entire basic idea behind RFA or radio frequency ablation. Now it depends which area ka RFA you want to do. Like over here, what they are mentioning is that patient has lumbar facet arthropathy. So maybe you are going to perform RFA to the lumbar spinal nerves. Okay. Over here in the picture that we see, the pain is probably related to knee pain. Okay. So that is why you are performing RFA of the genicular nerve. So the answer over here is there is destruction of nociceptive or pain related nerve fibers via heat lesioning. Okay. Next question. A 70-year-old man with advanced hepatocellular carcinoma presents with severe right upper quadrant pain radiating to the back. Despite maximal doses of opioids and adjuvant analgesics, his pain remains uncontrolled. So you have already given opioids, you have given adjuvant analgesics, maybe like NSAIDs, paracetamol, tramadol, the lower opioids. Okay. So all of that has been given, and the palliative, and it is cancer related pain. Okay. The palliative care team decides to perform a phenol neurolytic block for long-term pain relief. So remember, whenever your pharmacological treatment is complete, then you start thinking, if the pain is refractory, you start thinking of something invasive procedure. So the invasive procedure they want to do is, they want to destroy the nerve by giving phenol. Which of the following best describes the primary mechanism by which phenol produces analgesia? Okay. Now we know that phenol is a chemical component, and your phenol basically acts by axonal destruction via protein degeneration. Okay, so now how does this happen? So this is your, I've given you an example of a normal neuron. So in the normal neuron, you have different parts which you must have forgotten first year anatomy. So you have your axon and you have your myelin sheath that is covering the axon. Okay, so the axon is the body of the neuron and you have the myelin sheath covering the axon. Now this axon and myelin sheath both are majorly formed of proteins and fats. Okay, so what your phenol does is, phenol is nothing but a chemical. This chemical will go and it will denature the proteins, or it will damage the proteins that are forming the structure of the axon. So if the structure of the axon has been damaged, then obviously the nerve is damaged. The nerve is incapable of carrying the signals via it. So your axon will get damaged, your myelin sheath will get damaged because the protein structure is damaged and the pain signals will not be carried. So that is exactly how phenol acts. So I have also given it over here for you. Phenol acts as a neurolytic agent that irreversibly destroys nerve tissue by denaturing structural and functional proteins within the axon and the myelin sheath. Okay, simple. Just remember, body of the nerve formed by proteins. proteins are destroyed by phenol by its chemical action. Once the body is destroyed, it cannot carry any pain signals. All right. So that is our answer over here. Now, next one. A 68-year-old woman with severe back pain secondary to osteoporotic compression fracture undergoes percutaneous vertebroplasty to improve stability and relieve pain. During the procedure, PMMA, polymethyl methacrylate bone cement, is injected into the vertebral body under fluoroscopic guidance. Which of the following represents the most serious potential complication of this procedure? Okay, so what is percutaneous vertebroplasty? So just have a look at this beautiful picture that I found online. So in older patients, whenever they have vertebral fractures, okay, so you can see how the body of the vertebra has become very weak, and it has almost, the body of the vertebra is narrowed or compressed because of this vertebral fracture. Okay, so what you want to do over here, this, because you want to strengthen the vertebra a little bit. So how do you strengthen this fractured vertebra is that you can give a percutaneous injection. Percutaneous means radiological guided injection going through the skin. Okay, and that you go through the skin and you go into the vertebra and you inject some bone cement into it. Now, what does the bone cement do? The bone cement will basically increase the strength of the vertebra. Whatever are the broken parts of the vertebra inside, it will hold them together and increase the strength of the vertebra. So this bone cement that we use is a material which is called as PMMA or polymethyl methacrylate. Okay. Now, what happens is sometimes when you may inject a large amount of this bone cement, there isn't enough space, but let's say you inject a large amount of bone cement into this vertebra. There are these vertebral vessels that are present around. Okay, so because of the excessive pressure of the bone cement, they may enter into the vertebral venous system, and through the venous system, this bone cement may get embolized to the lungs. So what may happen is, while you're performing this percutaneous vertebroplasty, suddenly patient will start complaining of difficulty in breathing, dizziness, hypotension, and you will see that the patient is getting cyanosed. So these, and if you put monitors, you will see patient is desaturating. So all these are signs of your cement embolism. Okay, this commonly happens, and we study about it in anesthesia when we are studying about cement implantation syndrome, or when we are talking about cementing in TKRs or THRs, total knee replacement or total hip replacement. So same thing is happening over here. You are basically, the cement that you are putting it in the vertebra is entering into the blood or into the venous system and is getting embolized to the lungs. Okay, so that is called as cement embolism. So cement embolism to the lungs is something that is a potential complication of this procedure. Okay, now let's look at the other options over here. They are saying that while performing this bone cement, cementing of the compression fractures, that is percutaneous vertebroplasty, you may end up causing a spinal cord injury. Now remember, spinal cord is very far ahead. It's not that close, and this, in fact, length of the needle also most of the times is much lesser. So you are just focusing on the vertebral body. You are not going to cause any kind of spinal cord injury over here. Okay, hemorrhage from the vertebral venous plexus. Okay, so yes, there is a vertebral venous plexus, and you may end up like putting your needle into any of the blood vessels leading to bleeding. But again, from a venous bleed stops easily on its own. So a large amount of hemorrhage, which is going to cause a big hematoma leading to paraplegia in the patient, is not something that you will anticipate. It is not a potential complication. Also, you are directing your needle under fluoroscopy guidance. When you're doing these procedures, you have radiological imaging going on. So definitely you will be avoiding most of the blood vessels, and you will be going straight into your vertebra. Okay, and neurogenic shock is also not very common in this case.